Hi, welcome to POC Nurse, Point of Care Nurse. My name is Gozi. Today we're going to talk about cardiac surgery for the CCRN exam. More specifically, we're going to focus on CABG surgery, also known as coronary artery bypass grafting. In this kind of surgery, usually surgeons take an artery or vein from the legs, arms, or the chest and use that vessel to create an alternative path for blood to flow in the heart and bypass occluded vessels. So patients that need this surgery usually have problems with blood flow in the heart. So either the vessel in the heart is occluded or it's narrowed, but essentially blood flow in the heart is inadequate, leading to symptoms like chest pain and trouble with activities, things of that nature. So patients with diseases of the left main artery will usually require this surgery, along with if they have triple vessel disease, so meaning three vessels in the heart are occluded. Also, patients could have double vessel disease, meaning they have two vessels that are occluded in the heart. If one of them is the LAD, the patient likely will require this kind of surgery. The LAD is the left anterior descending artery. Patients might also need this surgery in an emergency. So, if, for example, the patient is in the cath lab and they're performing a procedure, and accidentally there is a dissection in one of the coronary arteries, they might need this kind of surgery emergently. So, to recap briefly, CABG surgery is done to create alternative blood flow in the heart. When is it done? It's usually done when the patient's coronary arteries are occluded or narrowed, meaning there's inadequate blood flow in the heart for some reason. Now, for the CCRN exam, it's important to know the complications associated with this procedure, and we're going to talk about that shortly. So, for the surgery itself, there are different approaches to it. The heart may be stopped during the surgery. In some surgeries, the heart continues to beat. It depends on the process the surgeon chooses to take. For the CCRN review, we're talking about the heart being stopped during the procedure. So, for the heart to be stopped, the patient is placed in hypothermia. Patient's temperature is between 28 degrees centigrade to 36 degrees centigrade. A lot of heparin is used. We don't want any clotting to occur. It might lead to strokes and other issues. And then, of course, the heart is stopped also with an infusion of potassium, the potassium cardioplegic agent, and they have to give it at regular intervals to make sure that the heart is stopped. Now, this agent could be warm or it could be cold. One thing to note that the longer the patient is in this bypass surgery, the patient might wind up bleeding more. Um, and the patient might also have more complications post-op. Now, some complications related to this surgery are cerebral or myocardial infarction. So the patient might have a stroke or the patient might have an MI. So in this case, we want to watch for the patient's neurostatus, and we also want to keep an eye on the patient's hemodynamic parameters. Now, these are things that could happen during the surgery. After the surgery, the patient could have heart failure with hypertension or pulmonary edema. So we want to keep an eye on the patient's hemodynamics. The patient might bleed. So the patient usually will come out with chest drains, chest tubes. So we want to keep an eye on the output in the chest tubes. Now, if the chest tube puts out if the chest tube puts out a certain amount of blood within a certain amount of time, we need to intervene. In this case, if the chest tube puts out greater than 100 mLs of blood for 2 consecutive hours, we need to let the practitioner know this patient might need a blood transfusion. We need to intervene some way, somehow do a CBC to see how it's affecting the patient's hemoglobin, and if it's causing any type of if it's making the patient unstable, something needs to be done. Usually the doctors will give a blood transfusion and continue to monitor the patient. You also want to monitor the patient for cardiac tamponade. This is something to note for the CCRN. Cardiac tamponade and pericarditis are two complications the CCRN is particular about, and that is noted in the books. So for cardiac tamponade, you want to make sure that the chest tubes are not clogged and that they are draining well. Because if they're clogged, the patient might retain fluid, and that fluid can go sit in the pericardial space and cause cardiac tamponade. We also want to monitor the patient for arrhythmia, so we have to keep an eye on the cardiac monitor. We need to monitor for electrolyte imbalances, so blood work. We need to do chemistries at intervals to see how the patient is doing. We need to monitor for bleeding. We talked about that already. We need to monitor for pulmonary issues. The patient obviously is going to be on the ventilator, and we have to try to wean the patient off the ventilator as early as possible. Patient might also have pain, patient might be anxious, so we need to medicate the patient for pain once they are responsive, of course. And even before then, patient might go into renal failure, so we need to monitor urine output for these patients. And we also need to have tight glucose control on these patients. So, which means we need to do checks at regular intervals and cover the patient with insulin if needed. And of course, as with every surgery, infection is always a risk. We need to monitor the patient's wounds, make sure they are healing well. This is where glucose control also comes in. We need to make sure that the patient's AccuCheck values are normal so that the patient can heal in good time. We also need to check for, so we need to make sure that the graphs are actually patent as well. So in this case, we're watching the monitor for STEMI. We're also checking the patient for chest pain or any sign that the graft has reoccluded. Some interventions for the assessments we do as nurses could be medicating the patient for pain. It could be replacing electrolytes. So maybe we've done our chemistry, potassium is low, we replace the patient's potassium. We talked about the importance of the chest tubes and drains that the patient comes out with. We need to make sure that it's patent because if it's occluded, the patient might develop cardiac tamponade. We need to also make sure it's patent so we know when and if the patient is bleeding. So if the patient develops some kind of dysrhythmia or arrhythmias, we need to administer antiarrhythmic medications as ordered. Patient may also require pacing. So sometimes they come out with pacing wires from the cabbage surgeries that can be used to pace if needed. These patients may also need inotropic support. They might also need vasopressors to support cardiac function. Another thing for the CCRN exam is is being mindful of the chest tubes in cabbage surgery. So the patient usually will have two types. One in the pleural space and another in the mediastinal area of the chest. So basically in the operative site. So the pleural chest tubes remove fluid from the pleural space. So in this case, we're talking about the lungs. It removes fluids and air from the lungs. The mediastinal chest tubes are in the operative site. So they remove fluid from the operative site. We talked about the importance of these chest tubes being patent. If they're not, we could have cardiac tamponade. And if they are, we'll know when the patient is bleeding too much or excessively. The chest tubes should always be lower than the patient's chest. Obviously, they usually are. They're on the floor while the patient is in the bed. And if the patient is able to get out of bed to the chair, the same thing, the patient will be in the chair and the tubes, the chest drains themselves will be on the floor, obviously lower than the patient's chest level. So the tubing attaching the patient to the chest tube shouldn't have dependent loops. So basically, we shouldn't have most of it looping to the floor. Also, we really shouldn't milk the chest tube, but if you see clots in it, they could be potential sources of occlusion. We need to try to milk those clots and get them down into the chest tube so that the tubing itself can be patent. That's pretty much what we need to know for cardiac surgery for the CCRN. Let's do a quick rundown, quick summary. So, CABG is cardiac surgery that uses a patient's arteries or veins harvested from their legs, arms, or chest to redirect blood flow around a narrowed or occluded coronary artery in order to restore blood flow to the heart. That's pretty much what the CABG cardiac surgery is. It's usually indicated when there's occlusion in one or more coronary arteries, most especially when the LAD is involved. Some assessment and interventions for us as nurses are to monitor the vital signs for the patient and check the patient for hemodynamic stability. If there's any problems in this area, we could always administer vasopressors or inotropic agents. We need to check for electrolyte imbalances if the patient is hypokalemic or whatever electrolyte is low, we need to replace that. If the patient has any kind of drains. Usually, the patient has a mediastinal and pleural chest tube. We need to make sure that they are patent and we need to monitor for drainage. We need to assess the patient for pain. Patient might have incisional pain, patient might have chest pain. If the patient has chest pain, we need to check for reocclusion of the graft, meaning we need to see if the patient is having a STEMI. Now, if the patient is just having incisional pain, we can medicate for pain. But even if the patient is also having chest pain, we still need to medicate for pain as well as assess for graft reocclusion. We need to also check the patient's glucose levels because this patient has incisions that need to heal. We need to support the healing process by maintaining tight glucose control. So if the glucose is high and we need to cover the patient with insulin, we should. Complications associated with the CABG surgery, the two most important ones we need to know are pericarditis and cardiac tamponade. Cardiac tamponade, we need to make sure that for that to be prevented, hopefully, that the patient's chest tubes are patent. Other complications related to CABG surgery are myocardial infarction, a stroke, bleeding, dysrhythmias. Here we can give antiarrhythmic agents. We could pace the patient. Hypertension, ARDS, acute respiratory failure, renal failure. We talked about electrolyte abnormalities, graft closure, harvest site infection. So the skin where incisions are made, the patient could have infections there. The patient could have GI issues like an ileus. This is the end of this video for cardiac surgery in the CCRN review. I hope you found it helpful. Please like, subscribe, and share, and I will see you in the next video. Bye bye now.